I'm sorry, I just couldn't hear
We
you.
can hear, we can't reply.
Yeah, we can hear it, but
We're not all signed
we're not
in,
going to be
so
able to
we can't
reply.
reply.
Yeah, we can't all like reply. That's the thing, because we're all just using one device or a couple
When you guys
devices.
just put your volume up, that's what we're doing.
That's what we're doing too.
Yeah,
No, I'm saying she's asking us questions, but we can't respond.
Yeah,
We're not all
that's
signed
what I'm
in.
saying as well.
Yes, we tried to tell her that.
Okay.
Yeah.
Just one person
Well,
put their volume up.
I'm going to tell you about the scoliosis when I see you. I'll see you in a little while. Anyway, so I'll show you how we figure out where the posterior and anterior rib bumps are. But to go on with this lecture, we can have a kyphosis, a scoliosis. Kyphosis is an exaggerated thoracic curve, right? And any of these types, scoliosis and kyphosis, can cause compromised breathing. Yes.
Convex leg spacing.
Okay, so don't respond at all. All right, I'll just talk. Can you hear when I talk? Okay. Okay, so then I won't ask questions. All right. All right, so you got out of it. Casey just told me what's going on, so I don't have to ask questions. All right. So if we have this scoliosis and kyphosis, or kyphosis, or increased kyphotic posture, we have an increased flexion of the thoracic spine. And any of these things, scoliosis, kyphosis, or kyphoscoliosis, can cause problems with breathing. Coxavara, as you remember from last year, is a decrease in the angle between the femur and the head of the head and the femur, and that decrease in angle is less than 120 degrees. So that coxavara can give the appearance of a shorter leg. If you remember that from last semester. So you could have a leg deformity such as bending and rotation. The treatment for any if someone has rickets, and very few people have it these days, but sometimes third world countries, people still suffer from it because of the deficiency. So what do? We do therapeutic exercise to make sure that we prevent any deformities, so we don't want any structural deformities come from any functional ones. Give this patient some vitamins, vitamin D3, and you can even do a surgical correction of the scoliosis itself or of any lower extremity deviations. Osteomalacia is a precursor in some people. No, actually I shouldn't say that. Osteopenia is. Osteomalacia would be adult rickets. So that's lack of mineralization of the new bone, and that results also in softening of the bone. It can also, you can see on x-rays something known as loser zones. So the loser zones are really a thinning in the wall of the bone. So you may see that. You may see some pseudo fractures, and they're radiolucent on an x-ray. You may see something affecting the scapula of the pelvis as well as the femur. Okay, softening of bone. Again, balanced diet, vitamin D, weight-bearing activities, more closed chain, because we want to try to increase bone growth. Osteoporosis, you had a whole lecture on it this morning, and its bone density will decrease, and as the bone density decreases, it can lead to a pathological fracture. So weight-bearing tolerance of the bone results in initial deformity of the bone, but remember, I think I gave you an example last year of some patient coming in, and I was treating her for a knee, and she said that her back hurt, and she explained to me that she actually went to play golf on the weekend, and she had a pathological fracture of the spine because she had osteoporosis. All right, so I really won't even go into this because you spent a whole lecture this morning on osteoporosis and the type of exercises. So Paget's disease that we could see here, it says bone remodeling is slowed down, especially in males. It's insidious. Insidious means we don't know why it happens. It's also referred to, if you see the term osteitis deformans, that's spelled O-S-T-E-I-T-I-S, deformans, D-E-F-O-R-M-A-N-S. So it's a structural deformation. It's also in the pelvis, in the tibia, the skull, and the low back. And you can see an increased kyphosis in these patients. And it says here, overactive osteoporosis. osteoclasts. So you guys remember what osteoclasts do? They actually break down bone. So the bone is absorbed quicker than it can be deposited. So that's what happens with Paget's disease. And it's the second most common bone disorder after osteoporosis. So the symptoms here, the patient will have pain, deformities, bone thickening, stiffness, coxavaris, vertebral compression, or collapse fractures. And the treatment is oral alendronate to inhibit this osteoclastic activity. It'll stop it. And NSAIDs, and everybody remembers what NSAIDs are, non-steroidal anti-inflammatory drugs for pain. NSAIDs, though, if you take NSAIDs on a great deal of time or a larger or over a certain amount of months or so, they could lead to GI problems. So know if a person is on NSAIDs and they start complaining of stomach pain or irritability, that they may have an ulcer or they may have bleeding. Prevent joint contractures with these patients, strength endurance, balance, coordination exercises, and orthotic if indicated, and PT after any kind of surgery for joint replacements. So when we talk about tumors and tumor-like diseases, we break them up into categories, and the categories are malignant tumors. And this is a big one, osteosarcoma, osteogenic sarcoma. It's sometimes fracture is the first sign that somebody has this. So they may come in and they may have pain and they may get a fracture. And then when they examine it on MRI and CT, they'll see that there's actually a malignant tumor. I've had one or two patients actually that have had osteosarcoma. One was on a isokinetic device. Because he came in and they wanted to see what his strength was like in that leg. And he actually was complaining of a lot of pain, so I sent him back to the physician, and they diagnosed him as having an osteosarcoma. Unfortunately, it was in the femur, and he had to have a high AK. They tried to salvage the limb if they can, but they have to remove the sarcoma itself, so they have to remove the limb. Distal femur is the most commonly involved, and it also can affect the proximal tib and fib. These patients will have pain at night, and what do we say about the pain? The pain is worse at night, and they may also suffer from some red flag that we talked about, which are night sweats, so profuse diaphoresis. And this patient did say that he couldn't sleep through the night because he sweat a lot. 99% of these tumors metastasize to the lung. Chondrosarcoma involves the cartilage. Often affects the axial and the appendicular skeleton. It's slow growing, and pain is really the most common complaint. And it can present really at any age. It really metastasizes, but when it does, it metastasizes to the lung. This type of cancer is thought to be resistant to chemotherapy and radiation. So treatment is surgical, so remove it. Ewing sarcoma originates in the soft tissue itself. Most common in people under the age of 20. Occurs in the long bones. Pain may be intermittent. You may see a mass. Of course, you're going to see a fever, a low-grade fever, or something that's waking them up at night. Sometimes they misdiagnose as osteomyelitis, which is an infection of the bone, but this is a soft tissue tumor. Responsive to high-dose radiation, chemotherapy, may need to do surgical resection, save what they can, and we improve function. Legg-Calvé-Perthes disease associated with, and I think we talked about this last year, aseptic necrosis of the femoral head. So when you have aseptic necrosis of the femoral head, you actually have tissue death. Complete revascularization occurs over time. So this happens in kids, and over time it may lead to a flattened head. And if it leads to a flattened head as you get revascularization, and the ball is not formed perfectly and it's flattened, it's like a coxaplana, and these people may wind up with osteoarthritis, degenerative arthritis later on. If they have degenerative arthritis later on, then it's usually associated with total hip replacement. Symptoms, intermittent pain, so the kid will have pain with limping, aching, pain in the groin, the entire limb, and usually when you pinpoint it, the child screams because it hurts. So we want to limit the deformity. The person can be in a brace or a splint of abduction, splint, and provide this patient with some kind of a pain modality. Osgood-Schlatter's disease, it happens in growing children, adolescent boys. Usually you could see it in girls too, but active adolescents, because the bone is growing faster than the soft tissues. So it's probably a result of an indirect trauma. What results is a painful, tender enlargement at the tibial tubercle, and it's associated with the patella tendon being pulled on and accentuated by activities such as running and jumping and kicking. And it's this force, the quadriceps, a repeated force against this quadricep becomes tight because it's not elongated and it's not, the muscle, again, in soft tissue are not growing as fast as the bone. So you could have, it can also be associated with abnormal alignment, such as an increased Q angle or a high patella alta. And it's considered sort of a form of tendinitis, or an apophysitis can occur if the part of the tibial tubercle avulses from the site. So this patient will have swelling, pain, tenderness over the tibial tubercle. It can become enlarged. I believe somebody in the class had Osgood-Schlatter's when they were younger, and if they would be willing to share that raised tibial tubercle, that would be great. Symptoms are aggravated by contracting that muscle. So what do we do with this kid? We tell them we rest. So we're going to make sure the kid rests and allow for that revascularization and that ossification. NSAIDs, ice, stretching, strengthening, and they may need a brace. Osteochondritis dissecans is associated with, it's a crack actually in the articular cartilage, articular cartilage, as well as the underlying subchondral bone. So there's there's deprivation, of blood deprivation in the subchondral bone, and that results in ischemia. And patient will have pain, swelling, and the limb would be giving away, and pains increase with passive knee extension and internal rotation of the tibia. What we do is immobilize the limb and strengthen around the joint, and gradually return this person to activities. These genetic and developmental disorders, I don't know if you've seen any of them or you've heard any of them with Professor Lawless, but osteogenesis imperfecta is a big one. It's associated with lack of type 1 collagen and little collagen synthesis. So when you have less collagen, it's easier to break bones. And sometimes these children, they are born with, clinically, they are born with fractures. So they may have 2 to 3 fractures. We once had a student in the program here. She said she suffered something like 60, 70 fractures by the time she was 3 or 4 years old. So, and hers wasn't as serious a case as some other children. But this is it's genetic disorder. It's congenital. I mean, you're born with it, and these patients may look absolutely normal, but they start to break bones, and they may be smaller because of the retardation of growth, especially if there's any problems at the growth plate. And you can see the severe cases can include patients having auditory difficulties, scoliosis, chest deformities, that's pectus, deformed teeth, cardiovascular complications, hypermobility of the joint, very thin skin, and blue sclera. So we want to prevent these fractures, educate the patient on what to do, positions the child in a way so that they don't have fractures, strengthen the hip abductors, extensors, trunks, abdominals, and maybe do some aquatherapy with these patients. Arthrogryposis multiplex congenita, it's a disease of newborns. it's multiple congenital contractures at birth. And they don't know, but they think it may have something to do, they know that there's decreased movement in utero, and with this decreased movement in utero, these joints may become fixed. So this clinical and possible causes are heredity, prenatal viral infection, a mother that's been on drugs, hyperthermia, vascular compromise between the mother and the fetus, and decrease of amniotic fluid. So these patients will be born with joint contractures, rigidity, muscle stiffness. It affects all the joints. They can have spatial asymmetry, club feet. You guys remember what that is? Adduction, internal rotation of the foot, or supinated foot, flexed, dislocated hips. They assume a frog posture. Upper extremities are adducted, internally rotated, etc., etc. So, and they may be delayed ambulation. So we want to do passive mobilization, positioning, and strengthening. Last thing, heel cord stretches, etc., things that you would do for CP kids too. The thing that's not on here that I should have put on here is Marfan syndrome, and I think we discussed it last week, MARFAN, Marfan syndrome. It's characterized by extremely long fingers, hypermobility of all the joints, unstable joints, scoliosis. It's a connective tissue disturbance. So it's a disturbance of the connective tissue, the way the connective tissue develops. And it's something that President Lincoln had. So remember that long face, long arms, spider-like fingers, excessive hypermobility, a lot of movement. So with these patients, we have to do a lot of stabilization exercises. Okay? So that's that. Now, let's do some gait and posture. So why do we look at posture? And what do we look at when we look at posture? We look at the alignment, right? Alignment of body segments. So we look at the head in relation to the shoulder, in relation to the hip, in relation to the knee, in relation to the foot. So it's in postural adjustments occur all the time, and postural adjustments require things such as proprioception, visual, and vestibular systems that work together with a musculoskeletal system. So our proprioception, our kinesthesia, our eyesight, our vestibular sensory system. And you'll learn more about that next year when you talk about spinal tracts. Okay, so if we look at a plumb line and we look at the lateral view, we're looking at this patient, and we could see that imaginary plumb line falls behind the apex of the coronal suture through the center of the external auditory meatus and the vertebral bodies, through the center of the thorax, through the acromion, okay, through the lumbar vertebra, behind the hip joint, anterior to the knee joint, but posterior to the patella, and anterior to the lateral malleolus. Okay, so posterior to the hip, anterior to the knee, and lateral malleolus. And if we look at somebody with a plumb line, and sometimes we hang them in the class themselves, ourselves, we also have grids, postural grids, which we have in our classroom right now. So from a lateral or sagittal view, we could look at the head and neck, and the plumb line should bisect the ear and go through the acromion. Again, we're anterior to the, posterior to the hip, anterior to the knee, and the ankle. And when we line a patient up in a postural grid or a plumb line, we do it from the feet up, because the feet are stationary and they're the only thing that doesn't move, right? If you line them up with their head, you may miss a lot of things, because the head may also be out of alignment. So midway, you're going to line, the plumb line is going to be anterior to the lateral malleolus, so that's the way you line them up, and if you put them from an anterior view, midway between both feet. Okay? So common faults that you can see from a lateral view or from a sagittal view can include things like a forward head posture. You could have a forward head posture with a posterior cranial rotation. We talked about that last semester. So forward head posture, we're looking at the angle of the SCM. We're looking, does it bisect the ear? If it doesn't and it comes forward, that patient has a forward head. If the head is rotated in a posterior direction, then we can call that a posterior cranial rotation. We could see if somebody's got a flattened lordotic curve or an excessive lordotic curve. We could also see if somebody is hyperextended. Wouldn't that be easier to see from a lateral view than from an anterior posterior view? Yes, it would. Okay. So, again, we're looking, head extensors are working, head flexors. This is the major anti-gravity muscles that maintain the erect posture. All right, so our neck extensors, our flexors, our spinal flexors, our abdominals, our extensors, our glute max, our hamstrings, our quads, anterior tibs, and as well as the gastrocnemius soleus. All right, so it says here, is the head forward? Is it tilted? Is it rotated? Does the neck appear to be tense or shortened? So does it look like we have a normal curve, or can we see some hypertrophy of specific muscles? Maybe we can. Are the shoulders the same height? We can't see that from a lateral view, but you can from an anterior or posterior view. Do they appear rounded or unevenly rotated? And we're looking at the waist. Is it parallel to the floor? Is one side higher than the other? Are the hips level? Do the hands drop at the same height, or is the carrying angle different on both sides? Are the fingers at the same area? Does the arm appear to be pronated? Does the shoulder appear to be internally rotated? Do the legs look the same? Do you see the same amount of hamstrings on one side as the other? Does it look like it's rotated? Are the knees knocking? Is there a valgus deformity? Is there a varus deformity? Is there hyperextension? Do we have an increased fic angle? Do we have eversion of the foot? Do we have pronation? Do we have supination? Do we have calcaneal inversion, eversion? These are all the things that we look at when we look at posture. Okay, so this is something like we have in the class right now. When we think about, this is from Florence Kendall's book, and Florence Kendall is like the mother of, she's passed away now, but she's the mother of muscular anatomy. She was an incredible woman. I was able to see her once, and she was fascinating. This was ideal alignment, and this is a kypholordotic posture, a flat back posture, and a sway back posture. So the definition of them are here. So if we look at this kyphotic lordotic posture, you see a lot of movement here. And you see the head is held forward, so forward head posture. The neck appears to be hyperextension because you have a great deal or an increased lordotic curve. If you were to see this patient from a posterior view, you'd see that the scapulae are probably protracted and anteriorly, not so much anterior tilted, but in a forward direction, causing the shoulders to round. The lumbar spine is extension, the pelvis is anteriorly tilted, the hip joints are in flexion, and the knees are in hyperextension. And the ankles are slightly plantar flexed, and that is evident because the tibia is a little bit posterior to this plumb line. In a flat back posture, the spinal curves are almost eliminated. The head is forward, cervical spine is a little bit in extension, upper spine is flexed a little bit, pelvis is tilted posteriorly, we could see that, hips are extended, knees are slightly hyperextended, you could see the femur going into hyperextension, plantar flexion of the ankles, and slight dorsiflexion of the ankles also. Sway back posture, the hips sink, and you kind of just hang on your Y ligaments, sort of, and you have an increased lumbar lordosis. Head is forward, neck is extended, thoracic spine is forward, lumbar spine is flattened, so flexion, posterior tilt. Hips are, again, you see the femur is hyperextended, and the ankle joints are neutral. Okay. So here's that sway back kid. Alright? And I just copied the same things that we just talked about. So that's that sway back posture, and this is what's happening. So if we're looking at these lines, we're seeing what's happening to the hip, what's happening to the leg, to the knee, where the trunk is in relation to the lower extremity. Kyphotic lordotic posture, again, it's just a picture of what we just talked about, and a flat back posture. Okay? So what do we see in this guy? We see an increased base of support, right? I would actually like you guys to look at this. Alright, and we'll discuss this. I'll put these up in class, and we can discuss it with the group. And this one, you could even see this is a postural grid, and they even put lines here, which are really great, because what do you see here? You see a lot, right? You see rotation, you see side bending, you see head at a midline. Look where that head is compared to where her midline is. You see pelvic obliquity. You see the chest, one side's lower, the shoulders, one side lower. Look at this carrying angle. It's non-existent, right? Non-existent. And what do you see with the shoulders going on? You see probably more pronation of the forearm here, but if we were to look at her without clothes and we look at it from a posterior view, we'd probably see a little bit more of internal rotation. We see a little valgus deformity here, so we don't really see her feet. And here I want you guys to look at this, and I really definitely want to discuss this. So, I want you to read through this. So, it says a 55-year-old woman presents with bilateral numbness, left greater than right, medial, anterior, posterior forearm, hands specifically, 3rd through 5th fingers, numbness, dead rubbery feeling, about 2 months. She sleeps on her right side. When she does, she gets symptoms. But in the past, she reported that she had 2 falls. The first was 10 years ago, and that involved right side contact, and the second 2 years ago involved occipital impact. Which resulted in a violent headache. Following the most recent fall, though, she experienced continual numbness in the upper extremities upon waking. Neither medical attention nor pharmaceutical intervention was sought by the client, yet she alluded to worrying about causative pathology if awake at night. So, let me tell you that she had CAT scans and everything else. They were all normal. Okay, so we don't have to worry about that. She didn't have a concussion, she didn't have a fracture, she didn't have a cervical fracture. I mean, those are the things you're going to worry about, right? Especially if she fell on the back of her head. Everything was negative. So here she is. All right? So what do we see? So I'd like you all to take a look at this and write down what you see. Go from the head down and make some comments. Alright, so you may need to even blow it up a little bit. Let's see if I can. I think that's as big as I can get it. Oh, shoot. See if let me see if I can blow this up. Alright, and you could do this with yours also, so that you could see if that helps, and make some comments about what's happening in her head, in her shoulders, what's happening, what do you see here, what do you see from here down, what do you see here, what do you see in the arms, what looks like is going on in hips or shoulders. Okay, it's difficult to see the feet, but let's concentrate mostly what we see up here, okay? And let's discuss going from this to this and think of any kind of a diagnosis we can come up with and what tests we might do to determine if we're right, okay? So I am going to come into the class now. So let's get out of this. You guys have this, right? Casey, you answer me. You guys have this, don't you? PowerPoint?
Yes, we do.
Okay. So, let's see if we can get it up on the, I'm gonna ask Professor D'Onofrio. Alright, I'm gonna end you.
So it's fifth finger and third finger.
Yeah, so it's on the nerve, and then so she stopped falling on her right side.
She
Like,
sleeps on her right side.
What?
She sleeps on her right side.
No, so her right side hurts a lot more, right?
She sleeps on the right side, yeah.
Okay. So it could be like
And,
maybe try.
oh no,
No.
that went smaller.
So you want present?
Yeah.
Where's the Jasmine?
Top right,
Oh, top right.
next to share.
Yeah, right there.
Okay.
Touch to it.
Well, like based on the case study, because of it's her third, fourth, and fifth finger. First thing popped in my head is like ulnar nerve compression in a way that's causing the numbness.
What do you think?
She's a little forward head posture. She seems to have an elevated left shoulder, which
And she seems laterally flexed to her right side.
not really flex to the right, so in between the
Her
forward
head,
head
her
posture.
head seems what?
Her body seems
Oh.
flexed to the right.
What about her head?
Yeah.
Midline? You think it's midline?
A little to the right.
What little to the right?
Her head.
Head.
is a little
What do you mean little? What does little to the right mean?
That's a technical term.
5 centimeters.
No, but what is little to the right? What do you mean little?
Her head is out of line.
Is it, what
So-
position is it
Her
in?
left shoulder's elevated, so
What
her-
position is the head in?
It's not flexed. It's like shifted almost. It's like
Well, it looks kind of
I'd say flex.
It's kind of
to the right.
Laterally flex.
No,
What, flex to the right?
no. It looks.
Where is her nose?
It's on the right side based on the photo.
So doesn't it look rotated?
Rotated. Yeah.
Oh.
I couldn't think of it.
I don't know, it's hard to tell with that black thing.
Yeah.
But it looks rotated, don't you think, now that I told you?
Yeah.
Yeah.
Okay. So it's a little rotated to the right, right? What else do you see?
Her right hip seems to be elevated over her left. So it's kind of hard to
Well,
tell.
what else do you see on the head? Anything?
For a little bit of forehead.
Well, let's look at this, let's just stay here.
The
What
right
else you see?
the right shoulder's dropped down.
The left is elevated.
The left is elevated.
I
Yeah.
wrote down all my things that I saw.
So left side, so left shoulder is higher than the right shoulder.
Yeah, what do we see here? Do we see anything here?
Maybe a bit of a curvature, maybe, like or a rotation, like you said.
Does this soft tissue look like that soft tissue?
Fold on the right side.
Spasm
What does it, a spasm, does it look like it's tighter?
on the left
Yeah,
side.
like a
On the left?
spasm
On the
left
right.
side.
Tighter.
left?
Tighter on the right.
On the
Right.
Yeah.
Like here, I'm talking about the anterior.
interior.
So like the SCM and the scalene,
because we can-
difficult to see, but what does it
that's
look like?
what's causing the rotation of her. I don't know. You would say like the
You
spasm
think?
could be resolved.
It could be. Yeah. Yeah, she's got a little bit more tone here, right?
Was that tightness or is it just that, so like if you were like flex your, to the right, the skin kind of like bunches up? Is that kind of what's happening or are you
Well,
saying that's
she-
like tightness in the muscle itself?
In this case, it's tightness. She's tight, but she is rotated. She is rotated.
Wait, so tightness on the left side or the right side?
Tightness on the right. Tightness on the
Because
right.
you can kind of see like the folds on that side of the neck. You see it there.
So the right, I see
It's
that.
tough to see the clavicles, right?
Yeah.
Yeah, I can't
Tough
really
to see the clavicles.
But I kinda do see the wrinkles you said on the right side.
Yeah, it's tough to see her clavicles though. It is. It looks she has a shirt on. Okay. So tough. But what about anything else? You notice anything else?
Are we still talking about the
Carrying
head?
on the right side?
This is another thing I noticed.
You still talking about the head?
No, let's talk about right here. You were saying this is higher.
Yeah, that's higher than the right
But
side.
what about how she looks from an anterior view this way? Does she look, does
It
the
looks like
left
the
and the
left
right,
side. Looks like the left side is forward than
left
the
side
right
is
side.
forward, right?
I think it's hard because of the photo.
Yeah,
but
it is,
like,
but
you
the
mentioned
left
rotation.
side is forward.
Left side is.
So the left scapula might be protracted, we don't really know.
Yeah.
But if you look here, doesn't it confirm what we're seeing here
Yeah.
as far as shoulder?
You can tell from that she's rotated?
Yeah, I can.
It's just tough, she's wearing a
It's
black.
tough, it's tough because she's in black and blah, blah, blah. But that's why when we do this on
Yeah.
the postural grid, you'll have no shirt on.
Yeah,
So we'll use you in it.
of course. That's what I expected.
Second,
In the back you can see
All right, so it even looks like, and it goes along with this one's elevated, that this hand seems longer. Yes?
right,
When
but
you look at this, is that distance the same? And is the carrying angle the same? How about the arms?
Everything will be on the right side.
Internal rotated, internally rotated
How about the
Is there
arms?
internal rotation?
of the hands a little bit, unless if she's
the
purposely
shoulders.
holding them there.
Yeah, and again, we're not seeing her in person, so it may be, she has a little bit more internal rotation on the left, maybe. And then you can see it here, because you see more of the shoulder, but we're not sure whether that's the shirt or the shoulder. So she definitely looks internally rotated, right? Good. What else was I gonna say? Let me see, oh. If you look at her, so we looked at her from a posterior view and an anterior view. What do we say about her cervical lordosis? Is this line,
It's not a line, no.
no? Is this line the same here as here?
No.
No. And we already confirmed that she looked like she was protracted on this side, right? Although, when you look at her from a lateral view, this actually looks better if you're gonna think about what the plumb line, where the plumb line should be, but it doesn't mean that it's better. It looks better, but it's not. It's worse, okay? Because she's got a forward head posture, doesn't she?
Yeah.
Yeah. She does have a forward head posture, but she does also go into, no, she doesn't really go into rotation. All right?
Professor, I have a question.
Yeah.
So you mentioned that like her head is rotating towards the right and there's tightness on the SCM on the right side too.
Does that make sense?
But like when we say like when so I would think like she would rotate if it's tight SCM, she would rotate towards the left side, right? I don't know. Or is she like flexed?
wouldn't the left SCM be tight if she's rotating to the right?
Yes.
So it's the left SCM that's tight.
No.
No.
In her case, she's got tightness here. She's got tight, she probably is tight on the other side too,
Yeah.
because of her rotation. But she's very little rotation, right?
Oh,
I
so
mean,
it's
there's-
not. So it's rotation towards the.
But it could be coming from the SEM, but it doesn't necessarily have to,
Okay.
okay? But if you look at all this congestion here, this is tighter.
So like the ridges are the muscles, right? You said.
Yes,
Okay, so
yes. And her rights and her scalenes are also contracted on the right. Are tighter, shorter, but not so to the point where they're gonna cause the rotation to occur. But she does have rotation to the right. Yeah. Does she have any side bending?
Yeah, to the right.
Yeah,
And she has side bending to the right?
a little bit.
By looking at the carrying angle.
What do you think? She's rotating to the right, is she side bend to the right?
Looks kinda like it.
On the
I can't
posterior.
tell really,
Yeah,
if
it's
this is
the-
her hair or this is her neck, I really can't
It's
tell.
like she's tilting towards the right side, so I mean, can we make
Well,
the
that
assumption?
would also help explain why her right hand is a little lower, in addition to
Yeah.
the left shoulder being elevated,
Yeah.
and there's a reduced,
Carrying
a little bit of a less carrying angle on the right, it's hard to say.
So given her history,
She fell on her right side.
Yeah.
given her history, and this tingling and this numbness and this things that are tight, what are we gonna think about doing? Any specific tests?
The, yeah,
Okay, Sperling's is negative. Why would you do Sperling?
that's for compression.
Compression of what?
Vertebral arteries.
Vertebral artery.
No, it's
The disc. Vertebral disc.
What does Sperling's do?
Compresses.
Subclavian?
Testing for HMP of the
So it
cervical.
compresses nerve roots, right? Okay, and if we had an HMP, that would be, and it was lateral displacement, it would probably be positive. It's negative.
And just for, to make sure, it's, rotate, and then, right from here.
And compression.
Rotate,
Extension. Compression.
lateral, rotate, laterally flex, and extend.
Rotation. Compression.
You're testing the right side.
So you wanna rotate and then back, and then flex.
Will we do the absence test too, precisely? Absence, the Roos test.
Those are more for vascular structures. Oh, no,
Like thoracic
Roos
outlet
can be
syndrome.
both.
I was thinking about thoracic outlet syndrome, like compression there. So like I was saying like Roos
Okay.
test, absence
Roos, yeah,
test.
Roos.
So Roos test, and then
Roos
an
test.
absence test.
Okay, Roos and Addison's are positive.
Okay, so possible thoracic outlet syndrome.
Secondary to what?
To
Scaling.
I guess the skin.
Okay,
Anterior
I will
sclerosis,
also tell you.
yeah.
you can't see it, but she also has an anterior pelvic tuck, anterior, what's the word I'm looking for?
Are we talking about
Scapular tilt, anterior scapular tilt.
so pecs are pec minors are tearing.
Also,
Yeah.
Guys, you're getting it.
that's basic.
Good.
We're just
So-
slow.
So,
Very slow.
Addison's positive, Rue's positive, she's got, and all this was found just from the postural exam.
Yeah.
So you looked at the posture and said, these are the tests I'm gonna do. Okay? So going along with that Sperling's, if it was positive, what else would you do? Yeah, what else would you do?
What would we do? To help her?
What else would you do? If you had a positive Sperling's test, what would you do? Oh, it's positive, goodbye, I'll see you next week.
Talking about like test wise or intervention?
That's why.
That's wise. Sperms.
Oh, yeah, you would try to try like.
You're right, you're correct, but let them think.
Like, you do like a short bump.
What would you do? Call me?
Is that an option?
ABCD.
Call a friend.
So you would look at the dermatomes, the myotomes, what else?
Well, you already know she has.
Well, I wanna make sure 1,000% that it's coming from up there and not from here.
What else would you do? Especially really important given this woman's history. Dermatomes, myotomes, and what?
Reflex.
Reflex.
Oh. Reflexes.
Yeah. Reflexes, right?
Yeah.
She was hyperreflexive, what could we be thinking? Maybe there was something that was missed in the cervical spine, or maybe she's got some cord compression now. She was hyperreflexive, we really have to worry about that, right?
Wouldn't that be upper motor?
Yeah, those upper motor.
if she had cord compression, yeah. Spinal cord and brainstem, brain and spinal cord.
So not necessarily on like the I guess like the C5 to T1 is like more on the spinal cord and the brain.
Yeah, well, because we said that maybe she had she had a fall, and affected the occipital lobe, right?
Oh,
So
yeah, she has that.
maybe something's going on in the brain.
So and result of violent headache.
And if you have a cord compression, you're gonna have exaggerated reflexes.
So you said they did CT scans, all that stuff, everything was normal. So if she had an upper motor neuron lesion, would you be able to see that on a CT scan, or you would have to kind of just test based on like her reflexes and all that stuff?
You would hope they did all the tests to see if she had a problem, but if they missed something, then clinically you're gonna.
Well, my question is, like, under normal circumstances, if you took a CT scan, would you see that? Would you see something abnormal in the brain to tell you that there's?
You should.
Okay.
However, you can't see everything with a CT. Sometimes you have to do an MRI.
But like imaging would tell you, okay,
Yes,
there is some
it
sort
should.
of upper motor
It should.
lesion.
I was wondering about what was written here. So there's more numbness on the left side than the right side, but then sleeping on the right side results in symptoms. I was wondering if like I thought that like in a case like this, where she fell on her right side and she felt symptoms on the right side when she's sleeping, wouldn't the numbness be a lot more on the right side compared to the left side, or is it like being compensated because of the posture?
She had more numbness on the.
On the left side, I'm just basing on what's
Okay.
written here.
She had more numbness on the left greater than right, right?
Mm-hmm.
Yeah, so she had bilateral numbness. And she was sleeping on the right side, it says?
Yeah, like so sleeping on the right side results in symptoms of the numbness in the left. So I'm not sure like if the numbness on like greater on the left side when she's sleeping on the right, or
I'm trying to remember.
Well, if she's tight on the right, and then she sleeps on the right, it can make it even tighter.
when her head
I'm
goes
trying to
side.
remember
Right.
this specific person.
Like, you go the opposite.
Yeah, I feel like when you sleep on your side, like it's more on like extension, like especially if you have like a pillow on that
pillow?
side.
Oh, so the pillow's
Yeah,
You're
pulling
gonna
to
flex
the
to
opposite.
the opposite side.
Yeah,
If
you
you
gotta
lay on the
flex
right
to-
side, you're gonna flex to the left side.
Yeah.
Mm.
Oh.
That's what was happening. She was lying on her
Okay.
right and flexed
Because of
to
the
the left.
pillow,
Yeah,
okay.
yeah. That's what was happening with this
It
patient.
takes her
Yeah.
out of what she's.
I forget, it was a long time ago.
Yeah.
All right, but the point though, that we're trying to show you is that you can see a lot from a postural evaluation, just like you can from a gait evaluation. All right, you may not know exactly what it is, but you know what's wrong or what somebody's doing. You know, like your early heel rise, where you're gonna look.
Like gastronic, maybe.
Could, yeah. Where else?
I guess like
Well,
weak, like in
Look at the knee.
tibialis anterior.
Yeah. Weak dorsal muscles.
Yeah, you can look a lot, right? You can look at the knee, see if there's any flexion deformity at the knee. You're gonna have an early heel rise like Linda. And Linda doesn't even do a heel strike when she walks. She doesn't even strike her heel.
If they had an early heel rise, that would be,
Could be a lot.
well, I'm saying, as far as the knee goes, that means they're not flexing enough.
Too much.
Too much flexion, okay.
Early heel rise, you said? Early heel rise, you're gonna see it right here, right? So I should be able to do this before my heel comes off. You'll
It's like
see,
tight
You're not extending
flexors.
the knee.
Yeah, you're not sending
but it could be because I have a little bit of knee flexion in that knee, which I don't, so it's hard to do, but you can see it in Linda because she does. So,
I watched somebody in the gym, he was wearing, he had like a knee brace on, he wasn't extending his knee all the way, and I was kind of watching, just thought he was doing that. He didn't have a heel strike, and it was,
so you didn't say anything, did you? And then you tempted to say,
yeah, I just, no, he was just walking along like the floor, and I was like watching him.
look like an assistive device or something.
Yeah.
I'm like looking at how.
Well, that's why I I saw the knee brace, so I was like, let me see what's going on.
So, you guys need a lot of help in gait, right? Oh,
Yeah.
wait a minute. We have time, right? Yeah, we have time. I'm gonna give you all a form, hold on.
Did you submit your daily symptoms check?
So we are, right hand
What?
side, to the neck.
I think SD.
Yeah.
Well,
I'd
if you
never be able to tell.
go to your Google
I don't
Calendars
need it.
on your Essex County email, it
Yeah.
shows you like to submit the forms. And you click that.
Behind
There's
those.
Yeah, what's behind the line?
One house
Yeah.
and you have a
So if you're
line
under your
going.
Essex
Yeah.
email, go to
Yeah,
Google
use the
Calendars.
plumb line.
Yeah.
That's your reference point.
It's just from a front view, it looks flexed and not really rotated.
Yeah, she wanted this to stay on the front view and I couldn't see there.
It should be there.
Yeah, so you better
Can
scroll
you give it
up.
to them and give me what's left over so I
it's
can bring it
tight
next
into
door?
the scale
You
leads.
guys are going to do a wheelchair and you're gonna have a mobilizer today, as well as a wheelchair. Let's get you through this, you do this, and I think